Okay, in this lecture, I'm going to do chapter 16 and 17 together. They shouldn't take long. There's just, again, a few things that I want to point out. So the first thing with blood and blood-forming organs, I really want you to look at the terms to know the difference between anemia, aplastic anemia, pancytopenia, and this seems to get students all the time, is a type of aplastic anemia in which red blood cells, white blood cells, and platelets are all deficient. So again, keep that in mind. So if you have all three of them, do not code all three out separately. You want to make sure that you use one code for those. With anemia, you want to be very precise when coding. So on that note, if it's deficient, you're going to be in the D50s, okay? And also, what is it deficient in? You know, you're going to be able to get very specific. If it's drug-induced, make sure you use that T code for what drug. Okay, here's the other big thing here is acute blood loss anemia. It's not a postoperative complication. When coding this, the doctor has to specify that it is acute blood loss anemia. So again, when somebody has surgery, they do lose a certain amount of blood every time. But again, the doctor has to document that is the reason for that type of anemia. Okay, then you have anemia due to chemotherapy. And with that, we do have a D code for that. Aplastic anemia, that is the failure of the bone marrow itself to produce red blood cells. So the biggest thing here in the blood section is to know what type of anemia and to code out the specific type. I talked about the pancytopenia at the beginning of the lecture. Verify the difference between sickle cell anemia and sickle cell trait. Okay, so with that, we're going to go through here. We have coagulation. The big thing here we get in with coagulation is we want to go ahead. There would be like a Z code for long-term use of a anticoagulant drug. So keep in mind that that's there too. Like I said, we have ProTimes, and there's my Z code for long-term use of anticoagulants. There isn't anything out of the ordinary for this section. That's why I'm going to go ahead and group it with our next section here, the nervous system. And we're going to go ahead and start that. So with the nervous system, chapter 17, we're looking at brain and the spinal cord, the peripheral nervous system, the eye, and the ear. Okay, so a lot going on in this system. Is anything really hard to code? No, not really. There isn't any big coding rules, so keep that in mind. We are coding Parkinson's for primary, secondary, Parkinson's with dementia, so there you're going to have two codes, the G code and the F code. Alzheimer's is a big one here. We have with early onset, late onset. Epilepsy is another big section, again, to code, but you read it as is and you code exactly just what they tell you. The one thing with this, with epilepsy, we have seizures, and make sure it's kind of like the same thing with AIDS and HIV. You do not ever code epilepsy with probable, possible, because somebody does not want that on their chart. The physician themselves has to clearly identify that condition, stating that before you can code it. So again, don't ever code epilepsy if a patient had a seizure. You don't know why they had that seizure. Okay, headache, it's all in this section too, with migraines. The next part is your hemiplegia. The biggest thing here is what part of the body, what side of the body. Again, default for dominant is right side. Default for non-dominant is left side. So you are okay to go ahead and if they say dominant, to go ahead and code the right side. If they say right side, you can't assume at that point it is dominant. Again, you just want to look at the documentation. Okay, just a couple of things when we're talking about a CVA, just remember this is a full-blown stroke. If we have a TIA, a transient ischemic attack, that usually the symptoms of a stroke will get better within 24 hours. So usually anything over 24 hours will be considered a stroke. So when doing that, we are looking at category G81. And again, just look at your documentation when coding these. Pain may be reported by coding or reporting the site of the pain. And these are going to be R codes. Okay, so with this, just make sure you read through your slides. In case there is something that you pick up, make notes in your book as you do look through these. So with the peripheral nervous system, these a lot of times codes in this section are manifestations of other diseases that are assigned as additional codes. Okay, disorders of the eye. With visual impairment, the biggest thing here is to code first the underlying cause of the blindness if it is known. Okay, so again, these are just everything. It's explaining the different codes out. There isn't any big coding rules to these. With a corneal injury, the only thing here, if there's an external cause, add that as an additional code. Okay, so with that we have dry eye, cataracts. One thing to remember, cataracts in older patients are not necessarily senile or mature. Make sure once again you look at the documentation. A cataract that is coded as diabetic, even in the absence of provider documentation, again, you have to have the documentation to code it that way. Same thing with glaucoma. Your third, fourth, and fifth character is going to classify the glaucoma type. Okay, with glaucoma here is a nice little chart. This is same type and stage, same type but different stage. So it just gives you a little bit more explanation on them. Okay, so then we get into the ear. With the ear, there isn't any coding rules or definitions that it's pretty much stated it is for documentation. So if anybody has any questions, let me know.